So I have no disclosures for this lecture. We're going to take a look at hypercalcemia and other disorders of calcium metabolism. So calcium, we said yesterday or day before, is absorbed by the jejunum. And the absorption is increased by 1,25-dihydroxyvitamin D. And it's also increased by parathyroid hormone. Calcium is excreted by the kidney primarily. Now, if you don't absorb it, obviously it goes out the gut. But the active excretion is performed by the kidney. And parathyroid hormone actually increases resorption. It tries to keep you from excreting the calcium in the urine. So hyperparathyroidism is not necessarily associated with an increased urine calcium. That's a spillover phenomenon because you're just mobilizing so much calcium the kidney can't handle it. Bone, you know, acts as a repository of calcium. Most of our calcium is in the bone, and the PTH mobilizes it when we need to stabilize the serum calcium. It's the job of PTH to do two things: build bone and stabilize serum calcium. And when it must stabilize serum calcium, then it resorbs calcium from the bone. Okay, so how can we preserve bone mineral density in our patients who are moving along after menopause? Once you're 8 to 10 years post-menopause, you've lost your estrogen-dependent bone, and so what you need to do is preserve what you have left. You can do that using calcium and vitamin D. Now, this is an old study, so if you need 1,600 milligrams of Citracal, you really only need about 1,200, but that was the dose at the time. And it will preserve bone mineral density. We know that not only from this very elegant study by Riggs, we also know it from all the placebo control studies. Remember, when you have an osteoporosis drug, the FDA now requires you to use 1,000 to 1,200 milligrams of calcium and give that to the patient. And it does preserve bone mineral density. That's why they require it. Now, you didn't think you were going to come to Kiowa and see roaches, but in Texas we have roaches all over the place. I have to tell you my mother's Florida story. We lived in Florida, and we had roaches because everybody, well, with the exception of the Pells, everybody in Florida has roaches in their house. They just live there, you know. And so my mother came, and she sidled up to me because she was from New England. And in New England, it is really tacky to have roaches. You know, no one in New England has roaches, unless they're really tacky. So she said, I have to tell you something, dear. She took me aside. She said, you have cockroaches. I went in the bathroom the other night and I saw a cockroach. I said, oh, Mother, you know, this is Florida, we all have cockroaches. She said, oh, no. She said, no. So I said, okay, I'll tell you, you will never see another roach in this house. I'll tell you how to do it. First of all, before you go into the bathroom, you reach in, turn on the light, clap your hands, you'll never see another roach. And it works. Okay, so the cockroach is here because you know how you kill a cockroach? You just step on it and you grind your foot. And you pick up your foot and it walks away on the concrete. You say, how did that happen? The cockroach has elasticity in its exoskeleton that has allowed it to remain unchanged for 300 million years. It's a very well-adapted animal. Why is that? Again, elasticity. And that's what you want for your patient's skeletons. You want them to be elastic. When you pick up a 30-pound plant pot, lift it over your head, you put a lot of torque on T12L1, and you want it to spring back, or it's going to collapse. And so this preservation of microarchitecture, or elasticity, is performed mainly by having adequate trabeculation, and to do that, you need adequate calcium. In fact, if you look at these two slides, the bone mineral density is the same here. One of them is an untreated person, and the other is a person treated with bisphosphonate. You say, my goodness, look at that osteoporotic bone over there. That can't be the same bone mineral density, but it is. You've thickened the struts that are there. Now, remember that bisphosphonates and teriparatide also allow you to replace some of the trabeculation, but they never restore this to that. And although this person has thin bones and osteoporosis, they still have about 4 times the strength in this bone because they have preserved microarchitecture and elasticity. And we know now that people who have thin bones because they're small, I look out in the audience, there are a number of you that are small people, and if you have thin bones because you're small, you're much less likely to fracture at a T-score of -2.5 than if you have lost bone and you've lost microarchitecture and your T-score is 2.5 and you're here. And even if I treat you with a bisphosphonate, I'm never going to get you from here to there. So the very important thing to remember about calcium is you need to get people on it from beginning to end of life because it helps them preserve their microarchitecture, not just because I'm trying to sell calcium because I own stock, and I do. So there you have it. Now we talked about recommended calcium, so we won't belabor that. You have the chart in your other handout. Okay, how about hypercalcemia? First of all, please get an accurate calcium. I mean, I see more people in my office that come in with hypercalcemia, and when I repeat it, when they're hydrated, they don't have it. Remember that fasting does not mean dehydrated. So, Mrs. Schmedlap, yes, you can drink water at night, drink water in the morning. If you usually drink water, drink it. We don't want you dehydrated when we get your calcium. The fasting calcium is the most accurate, but again, only if you're adequately hydrated. Remember that normal calcium varies with the lab, and it varies with the type of calcium done by the lab. Our comprehensive metabolic profile is really inaccurate. Its calcium runs about 0.2 to 0.3 higher than the actual calcium if you measure it separately. So you're worried about hypercalcemia, don't get an SMA 32, get a calcium level. And also if the albumin's abnormal, remember the calcium's abnormal. So measure the ionized calcium. When you're looking at these folks and you're worried about diagnosing a disorder of hypercalcemia, measure the ionized calcium. The exception to that is the cancer patient who has a port and really terrible veins. So if they have a port they're using chemotherapy for, you can't take the ionized calcium from the port. So with those people, I measure a usual calcium and do the calculation. But for the other folks, please, ionized. Now, what are the causes of hypercalcemia that you're going to see in your office? If you're in primary care, you're going to see hyperparathyroidism and calcium ingestion plus dehydration, renal disease, and occasionally malignancy. You're going to see a lot of people are on thiazide diuretics. As you get older and you take 1,500 milligrams of calcium and you take a thiazide, your serum calcium rides up. So you're going to see a lot of people that are going to have a little bit of calcium excess because they can't clear the calcium. And that's probably the most common thing you're going to see. After that, hyperparathyroidism, and down the way, malignancy. Vitamin D toxicity is incredibly rare. You can hardly give people enough D in this society, but recently people have been buying D3 on the internet in 50,000 international unit tablets and taking, I had one lady taking 4 a day who came into my office with hypercalcemia. And it's no wonder, because remember, vitamin D really does increase calcium absorption, and also it increases bone turnover. So she had 2 reasons to have hypercalcemia. And I said, ma'am, you know, that's too much vitamin D. And she said, I'm trying to live longer. I said, okay, if you want to do that on dialysis, keep taking this vitamin D. So again, have to have moderation with vitamin D. Some people overproduce 125D. People with, for example, granulomatous diseases, sarcoidosis being the most common. Occasional cancers produce 125D. And people who have hypercalcemia frequently have high turnover states. Patients with hyperthyroidism sometimes can have hypercalcemia. Patients with Paget's, you put them to bed, you keep them in bed for a week, they've got hypercalcemia. So it's very common in people with active Paget's or active rapid turnover bone. And also, of course, you may see familial hypocalciuric hypercalcemia, or as we all call it, FHH, so we won't have to remember which one of those hypos and hypers goes first. FHH is a familial disorder that is so rare that I've only seen it 3 times in 30 years of endocrine practice. You can cross it off your list. Now, how are we going to figure out why Mary Smittelfritz has hypercalcemia? First thing, get an adequate calcium, as we said. Then you're going to measure the intact PTH, and there are some labs that still don't measure that. So if your lab measures an N-terminal or a C-terminal or some other odd thing, just write intact PTH on your order form, and you should get the entire molecule, because the ends of the molecule that are sometimes measured are not as accurate to predict hyperparathyroidism. So you want the intact molecule, and please measure the calcium and the PTH at least on the same day. We really like them at the same time because you see they go up and down in parallel. So I get people coming into the office with a calcium of 10.6 on Monday, and 2 weeks later a PTH of 88. Well, when I measure them together, they're normal. Calcium may be a little up, PTH is suppressed. So again, remember they are in sync, so please measure them at the same time. In primary hyperparathyroidism, yes, the calcium is elevated, and the PTH may not be elevated, but it's inappropriately high. It's close to the upper limit of normal. In all the other causes, such as malignancy and vitamin D toxicity, the PTH is low. It may not be totally suppressed, but it's well below normal. Okay, how about malignancy? PTH is virtually always suppressed in malignancy unless the malignancy makes parathyroid hormone, and occasionally it does, but that's very rare. In general, you could say 95 to 98% of the time, PTH is suppressed in patients who have hypercalcemia of malignancy. They may make PTH-related protein, but you ordered the intact molecule assay, and so the PTH-RP does not assay in that, so you're safe. So intact molecule, virtually always suppressed in malignancy. When you think about malignancy, you may want to order the PTH-related protein. We'll see that as we go through the cases. And remember, it's made by lung, renal cell, ovary, and bladder cancer mainly. Also, lytic bone lesions can cause hypercalcemia. You're going to look for them with an SPEP or a urinary immunoelectrophoresis. And 125D overproduction, you can look for that by measuring 125D, but it's seldom found except in granulomatous diseases and a rare lymphoma. Okay, so this is in your algorithm, and it's in your handout. And so what do? You get the intact PTH after you know the calcium's elevated, and you go down one side or the other of this algorithm. If the PTH is elevated, then you either have primary hyperparathyroidism or FHH. And how do you differentiate between those two? Those two, you get a urinary calcium, because in hyperparathyroidism, it is normal much of the time or elevated. And in familial hypocalciuric hypercalcemia, that's how you get to be an endocrinologist. You can say things like that, or male hypogonadotropic hypogonadism. Once you can say those two things, they give you your certificate, and they say, okay, you're an endocrinologist. So always low in familial disease, never fails, always low. People never get kidney stones, and they hardly ever get anything else. So the reason to distinguish FHH, if you ever see it, is you don't want to take out their parathyroids, because then you give them a real problem. But primary hyperparathyroidism, urinary calcium can be normal, but it's virtually never low. If the intact PTH is suppressed and you have malignancy, vitamin toxicity, you want to then measure a PTH-RP, a 25D, a 125D. If they are all normal, then you want to look for malignancy involving the bone. You want to look for multiple myeloma. You want to look for rapid bone turnover states such as hyperthyroidism or Paget's disease. Now, using that algorithm, you can get rid of, actually classify nicely, about 99% of the people with hypercalcemia that walk into your office. And that's one of the NIH government algorithms. Okay, so now that we know what we're doing, we're going to look at a few cases. This is the constipated lady. I saw her because we saw her in the hospital because she had to have a colonoscopy then they just went up there and they reamed this out. She was what you might call totally obstructed by stool. Poor lady. And she was only 56 years old, and she just couldn't understand what was happening to her. For weeks, she'd had polyuria. Hypercalcemia causes polyuria. It makes you dried out like a prune. She'd had renal stones for years. She had osteoporosis at the hip, which is where hyperparathyroidism causes osteoporosis. She had cognitive dysfunction, which was the reason she got obstructed. She just hadn't had, I said, how long was it before since you had your last bowel movement? She said, I think about 3 weeks. Most of us would notice that. So again, she had a lot of cognitive dysfunction. Nice lady who was totally restored to a normal person by fixing her hyperparathyroidism. She had hypertension, and she had a calcium of 12.2. Her phosphorus was normal. It's a myth that hyperparathyroidism always lowers the phosphorus. PTH was 86, and our normal was less than 88. She was right up there, wasn't she? And her 25D was 16. About 60% of patients with hyperparathyroidism have a low vitamin D level. And you want to replace them before they have surgery, because if you don't, they're liable to have hungry bone syndrome and get hypocalcemic from that. So you want to replace them. And you say, oh, if I replace them, what's going to happen to their calcium? It's going to go up. Actually, the calcium in the serum goes up very little when you replace these people. The urine calcium can go up quite strikingly, and they can get stones. So you want to replace them a little bit gently. And when they're like this, when they're 16, 1,000 IUs of D will be perfectly fine. Just give her that for about 2 weeks before surgery, and she won't get hypocalcemia, hungry bones, and a lot of discomfort after the operation. And now remember, you have to really spiff people up before surgery, because they don't stay in the hospital. They go home, as I'll see in just a minute. Okay, so this is one of those. We're going to try this out. Does anybody have their clicker with them today? Turn on your clicker. Yeah, okay. Now, we have 4 options here. How would you make the diagnosis? I've sort of spilled the beans here, but would you just obtain a urine calcium because she thinks she has FHH? It's obvious she has primary hyperparathyroidism. You would obtain a creatinine, determine a calcium intake, and a urine calcium. She could have been ingesting a lot of extra calcium. She could have renal insufficiency. And number 4, it's a vitamin D insufficiency, and you don't need any more tests. You really need to know if the kidneys work. You also need to know if the patient's eating too much calcium. A urine calcium is sometimes helpful, but you really don't have to have it unless you think she has FHH. So very good. You did well on the first question. Okay, so let's talk about hyperparathyroidism, which is what this lady had. She had primary hyperparathyroidism with a mild vitamin D deficiency, replaced her D, and sent her to the surgeon. Once you know you have primary hyperparathyroidism, you can do a sestamibi scan. The overactive parathyroid takes up sestamibi. But it doesn't help you much with the diagnosis. You say, oh, Mary Jo has hypercalcemia. Oh, I'll do a sestamibi scan. Probably not going to help you. It helps you to know where the offending parathyroid is once you've made the diagnosis. 95% of people with hyperparathyroidism, primary hyperparathyroidism, have an adenoma. It's a solitary adenoma, and it lights up with sestamibi. The salivary glands also light up with sestamibi. So what they do is they don't get a parathyroid scan early. The surgeon gives you sestamibi to drink as you come into day surgery. We no longer put people in the hospital for this. They do intraoperative PTHs. So once they've gotten there, they say, okay, there it is. Take it out. I'm going to do an intraoperative PTH. The PTH ought to drop well into the normal range within minutes. PTH has a very short half-life in the serum. They say, I got it. They get out. It takes them under 28 minutes. It's day surgery, and they do it with local anesthetic. And I've had a patient status post MI who just had a local anesthetic. He was wide awake, chatting with them. They said, please don't put your arm in the field with the neck. But it's a very trivial surgery nowadays. And so when people have hyperparathyroidism, talk to them about surgery. Okay. Questions about case number 1? We'll just do questions as we go along. Okay. That was an easy one. This is all discovered by accident. She's an 83-year-old lady. She came in for a routine exam. Someone got a renal profile. Remember, the calcium's not tremendously accurate. Better than the comprehensive SMA 36 profile. This is a renal profile. They use it in dialysis, and so this is a little more accurate calcium. Calcium was 10.8. Repeated it with hydration. It went down to 10.6, and normal's 10.4. Oh, you say, this is really trivial. PTH was above normal. Oh, creatinine was 0.7, so her kidneys worked, and her PTH was elevated, and so was her calcium. Her urine calcium was slightly elevated, so she had primary hyperparathyroidism, right? Right. She was asymptomatic. So what do you do here? You're going to ask her what she's taking. Was she taking hydrochlorothiazide? That'll give you this degree of hypercalcemia. And if you're a little dried out, you'll get hyperparathyroidism. Is she taking a lot of calcium and she can't clear it? Anything else? No. So the fellow had seen her, and I said to the fellow, well, did you ask her if she ever had any parathyroid disease? He said, no, I didn't ask that. Why would I ask that? So that's why you're a fellow. I went in and I said, ma'am, have you ever had any problems like this before? She said, oh, yes. She said, you know, I had all 4 of my parathyroid glands removed when I was 35 years old, and I just don't want this disease anymore. And she had parathyroid hyperplasia, and that is the universal thing people say to you. They say, oh, no, tell me it's back. Because these people can have 6, 7, and 8 parathyroid glands. I had a gentleman who had 7, and by the time we found by arteriography the 7th golf ball sized parathyroid in his chest, he was pretty fed up with the whole thing. So they just get tired of it all. And frequently, as it recurs, the hypercalcemia is not very great. But what you need to think of when you find parathyroid hyperplasia, that's more than one gland involved, is that you need to think about multiple endocrine neoplasia 1. Now, has anybody ever seen parathyroid hyperplasia? No, it's very rare. 1, very good. And you thought right away of MEN1 because it's an autosomal dominance, so the patient's probably going to have it, and they're usually benign tumors of pituitary, pancreas, parathyroid. So if you ever think about that and you see someone with hyperplasia, this is what you get. And it will tell you about it screens for all those tumors. And you can rest assured that the patient probably won't have them, but you may have saved their life if they did. Now, this is not multiple endocrine neoplasia 2. You occasionally see hyperparathyroidism. It's frequently primary. It can be hyperplasia, but that's an entirely different disease, and you're unlikely to have it present with hyperparathyroidism. It usually presents with medullary carcinoma. Okay, so this lady is asymptomatic, and she said, the heck with this, I don't want surgery. So surgery is still the best alternative for these people, especially with Sestamibi scanning. We said you Sestamibi scan, she goes in, she's out same day, it's local anesthetic. I mean, it's reasonable, but some people don't want it, and if you get older, you may want it less. So again, when do you have to operate because you're going to get into trouble? If the calcium is 1 milligram per deciliter above normal, that's like it's going to be 11.2, 11.6. If it's above 11, people get into trouble. If they have a T-score at the hip that's -2.5, or they have an estimated GFR of less than 60, you've got to operate, because if you don't, they're going to have renal insufficiency, they're going to fracture their hip, they're going to have very significant cognitive dysfunction and hypertension from the hypercalcemia. So those are really must-operate people. The rest of the people kind of get a choice. And she said, nah, don't want surgery again. So they have to be hydrated. As soon as they have hypercalcemia, they have polyuria. As soon as they don't drink, the calcium can go up exponentially. I've seen people come in, saw a lady come in with a calcium of 21. Oh dear, hadn't been drinking for 2 or 3 days. Someone had actually been giving her calcium tablets. Things weren't going well. So lots of hydration, no calcium supplement. I'm sorry, we've got to treat your bones anyway, but we can't use calcium. Dietary calcium in small amounts, like 600 milligrams a day, just tiny bits of vitamin D, 400 IUs. And if you begin to get stones or a fracture, a fragility fracture, if you get abdominal pain or mental problems, and that includes, by the way, mania and depression. Some of those people can get very significant psychiatric problems. You have to follow the creatinine if it begins to rise. All of those are definite indications for surgery, and they've done huge studies watching these people with minimal hypercalcemia. And about 50% of them really do need surgery over a 10-year follow-up period. So most people should just have surgery at the get-go. You can also use a bisphosphonate. Remember, very effective to lower serum calcium. It stops the PTH from mobilizing calcium from the hip. So that's very helpful. Okay, questions? Boy, you guys are quiet today. But you're awake, I can see it. Okay, case number 3 is a 60-year-old lady with a calcium of 15. And she presented with what you'd expect: dehydration, disorientation. She had a blood pressure of 200 over 140. And she was thought to have hypercalcemia malignancy. So we hydrated her. What do? You give bisphosphonate. Which one? Zoledronic acid, IV. Best thing for hypercalcemia. But you've got to hydrate people. The mistake I see, we come on the floor and they say, we've given it. We gave the zoledronic acid reclassed. We gave the reclassed. And nothing's happening. I said, how many liters of fluid did you put in? Oh, fluid. Okay, right. In order to get the calcium out, you must get the fluid in. So you have to hydrate these folks. Her parathyroid hormone was 4 times normal, and her parathyroidectomy revealed a parathyroid cancer. Parathyroid cancer is fairly rare, but if you have really high parathyroid hormone at 200, 300, and your kidneys work, then we need to think about it. Now, despite the surgery, the hypercalcemia persisted. What to do? Cinacalcet is a calcium emetic. It binds to the PTH calcium receptor and says, you're full. And so the PTH secretion diminishes. And it not only is approved for parathyroid cancer, about 3 weeks ago, it was approved for hyperparathyroidism. So what are you going to do about the elderly person who can't have surgery, even day surgery under local? You're going to give them Cinacalcet. And if they have any renal insufficiency, Cinacalcet is paid for by Medicare. So you can use it now in primary hyperparathyroidism in people who cannot or will not have surgery and are having a problem with elevated calcium. It lowers the parathyroid hormone. And it reduced hers from 14.6 to 10.9. So 10.9 is a very tolerable place to live. So we now can save the lives of these people with tremendous hypercalcemia from hyperparathyroidism or from renal insufficiency. Okay. Case 4 is a renal problem. She's a 76-year-old lady with a calcium of 10.4. Oh, gee, this is pitiful. Normal is 10.3. I see people come to my office and I say, why don't you just drink some water before we measure this again? She was not dehydrated. Her BUN was about 20 and her creatinine was 2.4. So she was doing pretty well in the BUN department. She didn't eat much protein. She took 1,500 milligrams of calcium a day, and we said a couple of days ago that's too much, particularly for a 76-year-old lady, particularly if she has renal insufficiency. She was on Lasix. Her PTH was 256. Her 125D was low because she had renal insufficiency and she wasn't making it, and her 25-hydroxy-D was low. Okay, so now we're up to another question. What does this lady have? Severe primary hyperparathyroidism. Whoa, she has a high calcium and a PTH of over 200. Secondary hyperparathyroidism. She has renal insufficiency, low vitamin D, and a high calcium intake. Or an acute renal problem because of dehydration and she can't clear the calcium. Or a high PTH because of vitamin D deficiency. Aha. Well, most of you thought she had secondary hyperparathyroidism associated with renal insufficiency, et cetera. And you're right. Very good. Now, how about those people who picked number 4, which is D? You are also correct, although usually the D deficiency that we have there doesn't give you, oh, let me shut this off again, doesn't give you that much of an elevation of PTH. But yes, vitamin D deficiency can give you an elevated PTH. So either answer 2 or answer 4 was correct. We said she didn't have dehydration, so she didn't have acute renal insufficiency. Okay. Next, other questions about that one? I'm sorry, I should be asking you for questions here. No. Okay. Okay. So, case 5 is a 55-year-old lady who complains of bone pain and fatigue and generalized weakness. And believe me, I see a lot of people coming to my office complaining of pain all over, no energy, generalized weakness, and their renal function's perfectly normal. Now, she had a gastric bypass in 2006. Remember what we said about gastric bypass people? Bypass people have low vitamin D because they don't take their D and they don't absorb it very well, and so they have osteomalacia, I think. Her calcium was 9. That's normal. PTH is 180. So this lady has right off the bat secondary hyperparathyroidism, calcium normal, PTH elevated. That's what most people with renal disease have. People with gastric bypass have it. It's secondary. If the calcium is normal and the PTH is elevated, the PTH is elevated because it's doing its job. There's something else wrong that's driving the elevation of PTH. So again, her creatinine was normal. She has secondary hyperparathyroidism. We measured her 25D and it was 4. That is very significant vitamin D deficiency. And we're going to replace her vitamin D, and we're going to use 50,000 international units once a week for at least 8 weeks. And then we're going to measure it about 12 weeks and see where we are. She's probably going to need about 50,000 IUs twice a month or once a week for the rest of her life so that she won't be D deficient, have osteomalacia. Now, what's so bad about osteomalacia anyway? It increases your fracture risk by about 3-fold, for one thing, because you don't mineralize your bones. If you're a kid, you'll get rickets, but adults don't get rickets, they just get thin bones, and they can get bowing of the bones, particularly if they're obese. You can actually see, almost like rickets in kids, you begin to see their femurs get crooked. Okay, the key here is it takes months and more months after the D is replete for this PTH to go down. And I see all kinds of people coming in for bariatric surgery, and they're referred to endocrinology because they have secondary hyperparathyroidism. And the surgery people kept getting 125Ds. And I said, oh, this isn't going to work. Please just get the 25D. Well, now they've done that. But now I have to get them to just replace it so they won't send them to my office, because you just need to replace the D, and then you can have surgery, you can walk around the block, you can resume your normal daily life. The PTH does not go down for about 6 to 8 months. You have to be very, very patient. And you don't have to wait for surgery. We've chatted with them about that. So if a person comes in before the gastric bypass and they have osteomalacia, fix it. If they come after the gastric bypass, they're very likely to have osteomalacia, fix it. Okay, now I told you the answer to this, so we'll just skip that one. All right, how are we doing here? Okay. 76-year-old lady with known squamous cell lung cancer. She has thirst, polyuria, polydipsia. She takes no medicines, and she takes no calcium and no vitamin D. And her blood pressure was 90/60. She looked shocking. Her pulse was 118. She just didn't look good. Her BMI was 18. And the first thing she said to me was very sad. She said, oh, my cancer has been doing so well lately. And I thought, oh, not now. So her BUN was 70, calcium was 13.5, and her creatinine was 2.9. And her parathyroid hormone, as you would expect, was undetectable. So here's a lady, this is a very common scenario for people with, this is the most common scenario, for people with cancer, hyperparathyroidism hypercalcemia secondary to malignancy. Parathyroid hormone undetectable, calcium really high. So we replaced her volume, got her going, and here we have a question. What are we going to do with this lady? She has malignancy-related hypercalcemia. Here we go. Calcitonin, cinacalcet, prednisone, or zoledronic acid. Aha, there's some discussion about this, isn't there? Okay, well, the correct answer is zoledronic acid. It is the only thing you're going to be able to use in this lady. Now, prednisone, a few of you had that thought, prednisone decreases calcium absorption from the gut. She wasn't taking any calcium. She has hypercalcemia malignancy. So she has something mobilizing this. And what is it? Generally speaking, it's PTHrP. So she has a parathyroid hormone-like compound that is mobilizing her calcium from the bone. So she has PTHrP. Cinacalcet doesn't work for that. It binds to the parathyroid calcium receptor. It doesn't do anything about humoral PTH from PTHrP. Calcitonin, that was an okay one. Those of you who use calcitonin, you can use that for this condition. It's more unwieldy. It doesn't work for as long, and it isn't as potent. So calcitonin is okay, but the real answer is zoledronic acid, and somebody put E. Right. Okay, well, there's no E. Okay. All right, moving along here. Sorry about that. Okay, so hypercalcemia malignancy takes two forms. There's local osteolytic hypercalcemia because you're just mobilizing the calcium from the tumor site and releasing it into the circulation. And those are just cytokines. They're usually tumor-produced cytokines. Denosumab, by the way, that we talked about the first morning, stops that process very nicely. And then there's humoral hypercalcemia with PTHrP, generally speaking, sometimes 125D, that mobilizes bone, and that is not helped by denosumab. It's mainly helped by zoledronic acid. Okay, we're getting to the end here, too close to call. This is an interesting gentleman. He's a 50-year-old male. I'm sorry he's a male, but again, you're not going to want him to be a woman as we get through this. He was found to have a calcium of 10.2, PTH of 64. That's pretty well into the normal range. Creatinine of 1, so his kidneys work. His albumin was normal. He wasn't dehydrated. And he has minimal calcium intake. 2 glasses of milk is like 600 milligrams of calcium. So the resident said to me, why don't we just stop the calcium? Tell him to stop drinking milk. I said, well, that might do it, but something's wrong here. You know, when in doubt, order more lab. Okay, something's wrong. What makes the PTH higher than expected? You know, he's minimally hypercalcemic. Why is this PTH higher than I think? Why isn't it suppressed? Well, vitamin D deficiency. So we measured his 25-hydroxy D and it was 14. So he has insufficiency. So we need to fix that. What makes the PTH lower than you'd expect? If he really has primary hyperparathyroidism, why isn't the PTH elevated? What makes PTH low? Magnesium deficiency. Remember, no magnesium, no PTH secretion. So his magnesium was a bit low, so he's not secreting the PTH we'd expected. And I said, this is odd. Let me ask this man another question in his history. I said, do you drink alcohol? And he said, about 48 beers a week. Remember that alcohol causes an incredible diuresis of magnesium. And actually, your serum magnesium may not reflect the total body magnesium deficiency should you drink 48 beers a week. That's a lot of beer. I mean, that's like, well, you know. He said, that's not really a whole lot of beer, Doc. He said that's about 6 to 7 beers a day. Okay. So after supplementation with magnesium and vitamin D, his calcium went up to 10.4, and his PTH went to 110. And so what did he have? He had primary hyperparathyroidism. But more importantly, he had terrible alcoholism. So we tried to fix that first. Okay. Hypocalcemia. We'll spend a bit of time on that. 55-year-old lady who's status post-surgery for papillary thyroid cancer. The main cause of hypoparathyroidism on the face of the earth is surgery. You know, people take out tumors in the neck. They do radical neck dissections. Remember we said that parathyroids can be anywhere from here to there. And so as a result, they remove parathyroids, and they may remove some they don't see. They don't look in the pathology specimen. Carefully enough, these are very small glands, and you may miss them. So she just came into the office. She was asymptomatic, and her calcium was 7, and her phosphorus was 5.8, and creatinine was 1. So she had normal renal function, hyperphosphatemia, and low calcium. So she has significant hypoparathyroidism. So what's the next step? Okay, go. Repeat the calcium. It must be a mistake. Check the pathology report for parathyroids. Supplement with a lot of calcium, or supplement with calcium and 125D. So how are you going to fix this lady? If you found her parathyroids in the pathology specimen, you can put them back in. It's a little late when it's fixed, but you know, when you're staying. But before that, if you find them in the operating room, and that's why they do intraoperative PTHs, is they can see if the PTH goes down. They can find the parathyroid in the specimen and put it back. They can put it back in the sternocleidomastoid. They can put it in the forearm. It works nicely. Okay. Let's take a look here and see what we got. So we can go on here. You're going to use the least amount of calcium possible, and you're going to give her some probably calcitriol. There are other things you can use, but calcitriol is generic. So you don't want to use much more than 1,500 milligrams of calcium in the hypocalcemic person, because they're going to get constipated like a rock. They're going to be uncomfortable. They get bloating. So you want to cut back on the calcium. You don't want to use 3 grams of calcium. You want to use a little bit of calcium, 1,200 to 1,500 milligrams, and use some 25-hydroxy-D. And usually about 0.25 to 0.5 micrograms per day will do it. You have to watch for hypercalciuria and elevated serum phosphorus. Uh-oh, she already had an elevated serum phosphorus. Well, she wasn't really taking any calcium, and calcium is phosphorus binder, so I started her on 1.5 grams of calcium. She wasn't symptomatic, you recall. And I said, okay, now we're going to take a look here and see what your phosphorus is. It actually went down. But if, in some patients, the hyperphosphatemia persists, you have to use a non-calcium phosphate binder for them, something like Renagel. Okay, so what are the causes? We said head and neck surgery, far and away. But you can get an autoimmune destruction of the parathyroid glands. If you have enough radiation to the neck, you can destroy the parathyroid glands. And of course, some people are born without them. Okay, so in hypercalcemia, you're going to measure the PTH, and it's high in hyperparathyroidism and FHH, and you're going to replace the vitamin D in those folks. That's a very important point. And the PTH is suppressed in all the others. Okay. And hypocalcemia, again, common cause, thyroid surgery. So think of that in your folks who have tingly feelings, paresthesias, and have had thyroid surgery. And you want to use both calcium and D.